About 7 years ago, we had a program called Basecamp, which we ran with Niagara College. And at that time, the new periodontal classifications just came out. And we were really excited to implement them and to use them in practice. So we put together a series of very, very fundamental lectures that are sort of mandatory competence that you have to understand this if you're going to be practicing perio as a dentist, as a hygienist, just main points that we have in there. So this, it was really exciting because I'm used to talking about all kinds of crazy things. Some of you, like Bernie, who's been here many times, we bring in veterinarians and lawyers and we bring in all kinds of things, but we sometimes get away from our fundamental perio parts. And that is something that we want to focus on in this series that we have running for the next year and a half. So the purpose of this is really to review these guidelines from many years ago now, and then see how they have stood up in practice, in a periodontal practice, 7, 8 years later, right? So this is the goal of what we're going to be doing over the next number of lectures. And I'd like to thank you for being among the first, because you are going to have a really good view of what perio looks like. My colleague, Dr. Schultz, she's going to be joining us soon. She's going to be co-presenting with me. And we have Kathy Ham and Donna Lavoie, who are very experienced hygienists that are also going to chime in when the time is right. And I was thinking about, why not do this online? Why not record this and everybody can watch it at their own leisure instead of bringing you all in a spot? Well, as a perpetual student, I've learned that a lecture is a really great place to trade ideas. It's not just one directional. It is something where we have that unanticipated magic that happens either during the break or during a discussion, or somebody has a question, and that really enlightens and fills the room. So I want this to be interactive. I want this to be not a one-way street, because I don't have all the answers. I practice perio as my main gig. Been doing it for 25 years. I love doing it. My goal is always to be a better periodontist next year, and I want to drag you guys along with me. So this is sort of the point of what we're doing. Any questions before we start with that? I should also tell you where we're going with it. So this is 2 sections. So there's a part 1 and a part 2. And in the middle, we're going to have about a 15, 20-minute break so that we can kind of stretch and get rejuvenated. I promise I'm never going to waste your time. Any of my lectures that you come, I want you to take a lot away with you. We have an app that we created in 2018 called Dr. Peter Fritz, and it's a free app, and it has all of the jewels and some of the slides that we have, and they're available for you to look at. They're gems in a treasure box that we've created. So that's something that you can take. So a lot of these slides, when they have when they have a ruby or a piece of jewelry, you know that it's in their treasure box in our site, right? So also we were supposed to have Caprice from our Vitality Derm Surge clinic here. You see, we partnered with a dermatologist and a general surgeon, and they have a device which actually is kind of cool. It's called a Visia. So it photographs you from different ways, and then it uses AI to compare your skin quality with a database of thousands and thousands of other people that it's done. I won't tell you that when I put my head in this, what happened, but I was disappointed and I bought some cream. So we're working on that, right? And I needed some cream because I've just come back from over the holidays. I was down south. I was very south, very, very south. I was at the South Pole. And on this adventure, I was sure to bring my Oral-B, my IO10. And this slide is here to remind me to thank Kat, who is one of our sponsors tonight, our main sponsor tonight. And she has her station in the back. She's been a champion of our practice. I would never have someone here that I don't believe in their product, and Kat is just an extension of our practice, and she's just wonderful. And for those of you who use toothpaste, she has some samples for you tonight. So there you go, right? All right, well, we've done the introductions, you know who I am, and I've shown you this slide before, that if you ain't the lead dog, the scenery never changes. But what we want to do is we want to see if the scenery has changed since we've explored this a number of years ago. And together, we're here as peers, right? And that's a really powerful connection that we have. That we've got people that do exactly the same thing you do, and what you do every day isn't easy. Right? It's not easy. You have so many personalities that you have to manage during the day. And you might see 7, 10 patients, might see 30, 40 patients. And who is the patient that comes home with you in your mind? Right? The one that didn't go so well, right? How that could have gone better. And this is the curse of being a dental professional. Right? So I even take my patients with me on vacation, right? And I think about them. I've learned that attachment is something that you can often, if you detach, that's something that's really helpful. But your team here, your peers, they're such a valuable resource because they understand you better than most people do. Another part is that we're sharing some critical information. There's always external information and internal information. The external is what the papers say, what the peer-reviewed journals say, and that's one thing. But there's also the internal data. That's the data that we have that, can I get this to work in my hands, in my practice? Can my hygienist actually do this that was described so brilliantly in this journal? So the only things I'm going to present to you are things that we have validated here. This is a living laboratory that we have here. We have graduate students, we have Niagara students coming through. We've got all kinds of learners here, medical students now, and it's one of the best things about our clinic is that we're very transparent. We haven't figured everything else out, but we strive that we're going to be better next year. And it's also a safe space. It's a space to ask questions, right? If you're not sure about something, pretty sure that somebody else in the room isn't sure either. So together we're going to be able to sort of get the best kick at this, which I think is really valuable. This has been my mantra ever since I became a student, which is never stop learning because the world around you never stops teaching. And boy, it teaches all the time. And those of you who are on journeys for learning, I think it's amazing. I want to send a special acknowledgement to Joe in the back. Joe is heading to Uganda on Friday to do the Build Your Smile Foundation with Dr. Barzilai's group. And that's the group that I participated with last year, and we paddled across Lake Ontario in this canoe to raise funds for the Build Your Smile Foundation. And Joe is going to come back transformed when we see him next, because he's going to be experiencing things that very few people have ever experienced. This is on the border between Rwanda and Uganda. He'll be working out of churches and doing hygiene and all kinds of other things, I'm sure. So on to our business here, and this my esteemed colleague, the incomparable Dr. Schultz, is here, and she's going to correct me when I go astray, and she's going to, of course, add wonderful things to this lecture. And we're going to help demystify the new classification system, which really isn't new. Interestingly, the CDHA is having a meeting in conjunction with the American Academy of Periodontology in October, right? So it's in October, mid-October, it's 3 or 4 days. They were kind enough to invite me to speak to their leadership group on the Friday about AI in dentistry. And they mentioned that they have a lecture coming up where there's a clinician from Dalhousie, I believe, that's doing an online service for them about this new classification system. And they have almost 2,500 hygienists signed up. And I'm like, which system is this? And they said, it's the new system. I'm like, the 2017 system? And they're like, yeah, well, this is the system we've been using for a long time. So, like, okay, so then this is information that is not so readily available. I know some of you have heard it before, but this is something you're going to be jumping into, and we're going to be able to help you with that for sure. So I mentioned the external information, the internal information, and what we're trying to tell you is the right information. And nobody really has this, is as versed as this as the hygienists that we practice with in our clinic here. They have enormous experience in seeing this transformation over the last 2 decades over how we handle this and how the new classifications built into this is really quite unique. So does anyone know what the definition of a specialist is before we get started? Definition of a specialist is someone who does almost everything else worse, right? I only do 7 things. And those 7 things we do very well because I've done them thousands and thousands of times. And along the way, I've made lots of mistakes and learned a lot. And by doing that, you kind of get better at it. So you either do that or you go into tap dancing, right? But this is what we're doing. So the 2 things that a periodontist does, interestingly, is we open and close wounds probably better than any other specialty. And the reason that we do this is because of the way that we handle tissues. We're able to open and close these wounds and bring things together in a way that's very unique. And it's the frequency of which. I don't know how many stitches I do in a day. It's at least over 100 every day. And you know, I tie knots for a living, and as does Dr. Schull. The second thing that we do, and so we're not going to teach you how to tie knots in this group, in this course. But the second thing I do is we function kind of like actuaries. So isn't that boring? What does an actuary do? An actuary predicts how long things are going to last or how things are going to go. And so the ability to analyze and integrate a bunch of different things to determine what the long-term prognosis is. So you see a patient that has periodontal disease, and as a periodontist, you pull a bunch of different things, and tonight you'll see those things that we look at to kind of decide how long this dentition is going to last, and what is the individual prognosis for individual teeth, and you know, sort of visioning and predicting the dental future for this patient. It's also a great way to share responsibility, right? So you are able to say, okay, can we build a bridge on this, or can we have a partial denture attached to this? Right? So that's the second advantage. And you know what's going to change this enormously is AI. Right? AI wasn't on the horizon for this, but we're actually in the process of building a couple of things. One is revising our situation where how we determine prognosis. But the other thing that we're building is a debridement difficulty scale that's powered by AI to help predict how difficult this patient's sanative therapy is going to be. So that's something that we have underway right now, and we'll have that ready to go by the time ISDH is out, which is in 2026 in June. So we'll probably present it there. So things change in 2.5 decades. If you think about your phone in 1999, that's when the last guidelines were out, right? And your phone today and just the type of car that's available then and now, things change rapidly. And you know, the future is never going to be as, the pace of development is never going to be as slow as it is right now. You can only expect it to accelerate. So why did they even do an update, right? What was wrong with 1999? That worked well, you know, it was going fine. Why do we stir it up, right? Why do we do that? Well, a group of very forward thinkers got together for this consensus, and they got together, and sort of the brightest minds in perio, notably Louisa and I were not there. I'm still waiting for my invitation. I thought that maybe, but that was a while ago. But anyway, they got together. They wrote 19 review papers and 4 consensus papers. And that distilled it down, and they were heavy papers. So what we've done is we've condensed that into a number of presentations for you, a number of discussions. You know, you could also put this through ChatGPT, and you could distill it down even better. And maybe we'll do that for one of the lectures. But for now, I think it warrants a bit of discussion, because one thing that's really different when you're discussing this versus reading the paper are the visuals. Right? The visuals are really important. So let's explore this together, and the journey starts right now. I mentioned the treasure box, and so when we see the treasure box in the corner, that means that we have that slide is on the app for you to review there. This is our map. This is our journey of our odyssey, and what we've done is we've stratified this into periodontal health and gingival diseases and conditions, periodontitis, and we have 3 subcategories here, other conditions affecting the periodontium, which are here, and then peri-implant diseases and conditions, which are down there. And this is way too much to go over in one evening, right? So we've broken it down into a number of small lectures, a small number of nibbles that we can look at. And you know, I'm not going to plow through it just for the sake of plowing through it. I want to make sure that we understand that we're comfortable with one before we move on to the next. So not necessarily will we be finishing every lecture. We may have to extend that onto the next. But the main thing is I want you to be clear about the section before we move to the next one. Does that make sense? Okay, cool. So yeah, so lecture 2 is going to be on periodontitis, systemic manifestations, periodontal health conditions. We're going to do a lecture on implant health, conditions affecting the periodontium. So we've broken this down into all these different subheadings. And over the course of this program, we're going to be knocking all these down. And hopefully you'll have a really good understanding of these. So let's talk about health in gingivitis. Any questions up to here before we move on? Anything else we'd like to add, Louisa, at this point?
One of the other really big differences between reading the papers and going through it this way is that we have each other. So Dr. Fritz was mentioning it earlier that we really love feedback, we love questions. If one of your neighbors probably have the same questions you have, and only to bring his hands go up. So feel very free at any point to stop us, ask questions, ask for further information if you want to learn more, or just ask questions about something we didn't explain well.
Yeah. Cool. So these are the questions that we're going to answer in this sort of these concepts today. Why do we need these systems? What should a system today be based on? How do we classify health? How do you define periodontal health? You kind of look at it and you go, yeah, it looks okay. Right? No, there's more to that. There are words that we can use to describe that. And how do we classify disease? Well, why do we need measurement and classification systems? Right? Well, we need a language to communicate to each other. You want to be able to put words to what you're seeing and words to pass on to other people exactly clinically what you've seen. You also want to be able to communicate that to the patient and to enable proper diagnostics and to be able to predict what's going to happen for that patient. You want to make sure you have the right words so that you can line up the right treatment with those words. And this helps us to discuss with other clinicians that don't speak the language in our area. It's a common language, kind of like something that's over the language of perio is boiled down into these classification systems. So if you're in Europe or in South America or wherever, you're all talking about the same disease classification. Yeah.
Or Ugandan.
You're Uganda, yeah, right, there as well. And lovely with this is because then you can publish research papers and you don't have 15,000 different classification systems for perio that are comparing each other. So now you can do meta-analyses and you can do subjective research with this. So this is why we need these systems. So what should the systems be based on? Well, it'd be lovely if we had a biomarker that you could just swish something and then you could see, well, you have this, this issue. But that unfortunately is not something that's very helpful. I know there's a movement to do bacterial testing again. The pendulum has come again for that, where people are saying, well, we should really see what kind of bacteria there are in the mouth. And it's like, you know what? We sort of figured that out about 50 years ago. We have patients with perio. These are the bacteria they're going to have. Like, it's not going to be a surprise, right? There's no need to do that testing right off the bat. That's really sort of a waste of time to do that. A contemporary system should be based on etiology, pathogenesis, and a clinical description of the pathology, right? So we have these things that we're able to look at what causes it. So let's base our diagnosis on etiology and pathogenesis rather than somebody's name, right? So it's nice to have, I heard today Ehlers-Danlos syndrome again, and I'm like, well, that's really nice that it was named after that, but it's like, okay, well, it would be really great if we could narrow that down into something else, right? So let's base it on something that's understandable and helpful rather than complementary to the person who discovered it. So with periodontal health, what is health? Well, the World Health Organization defines it as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity, which is a nice holistic kind of definition, I think. And periodontal health is a system, a state free from inflammatory periodontal disease that allows an individual to function normally and avoid physical or mental consequences due to a current or past disease. That's how they've defined periodontal health. It's not, doesn't say anything about bleeding on probing there, right? So, but this is, so you're asking the patient. So someone's asked the patient how they're feeling about this and how they're feeling about the past of this, right? It's really nice to be able to include the patient into these discussions, because it's not the chef that tells you how good the meal is, right? It's the patient, the diner. So how do we classify disease? It's just the fourth part, which is we use this special table here. I've taken away the perio or the peri-implant classifications. That's a different thing. But this is the first gem that we have in our app. And this is how that's been classified. So I reviewed that with you earlier. And we're going to start here in pink with periodontal health and gingival health. So pristine clinical health, rare. You're shocked, I know. But it's realistic. It means that there's no attachment loss, no bleeding upon probing, no sulcular probing more than 3, no redness, clinical swelling, edema, or pus. Right? That's sort of what is the definition of clinical health. And clinically healthy means that there are very few clinical indicators or inflammatory markers in the clavicular fluid that suggest that there's an inflammatory process. Now, I should say that it's great that we have these inflammatory markers to look at. We find in our clinic that it's not really something that we rely on. Right? That's a marker that's interesting from a scientific point of view, but it's not really a marker that we rely on virtually at all to help with our diagnosis. So you should be wary of people that are telling you otherwise, because what difference is it going to make from your clinical treatment? What's the benefit to the patient for them having had this test, having this information?
Yeah, and we know that a lot of people have different combinations of bacteria, but if you go back to kind of your first little bit of hygiene training or periodontal type training in dental school, you have like the different circles where you're talking about systemic factors, local factors, environmental factors. Just managing the bacteria doesn't manage the disease. Okay, we have to find this patient. Why is their immune system reacting in this way when they're confronted against this aggression caused by the bacteria? So we have to kind of counter for all those factors when we're treating our patient. Knowing what bacteria they have in sulcus doesn't change that. They're still a smoker, but they might be a diabetic, or they have over-contoured restorations, calculus below the gut line, or below the gingiva, that is, making their situation worse. Managing the bacteria alone is not going to help the patient. We have to manage all those factors, and there's no test that tells us all that, other than interacting with our patient and getting to know them, going through our medical histories, and opening that conversation with them. So I don't lab test doesn't do that for us.
I know I once got into an argument with, very early in my career, with someone who I was practicing in Burlington, and they were doing a lot of biomarker testing for their patients. And I was sent a patient, and they asked me about biomarker testing, and I'm like, I don't do that biomarker testing. I don't think it's valuable. So the dentist phoned me up and was very mad, and he said you should really learn about this biomarker testing. And in my mind, I'm thinking, you should really learn about overhangs. Because I think, yeah, anyway, you know where I'm going, okay? Yeah, so anyway. All right, so, but we have this heightened inflammatory response. It's clear for some patients have a much higher inflammatory response than others. And you have this surveillance, these polynuclear leukocytes. They're like little sheepdogs. The surveillance is always on. And it is important. It's always there. But it is something that's really more of a scientific interest to me than a clinical interest. Now, more interesting to me is this first slide here. How do we determine if the patient is healthy or not? You need a periodontal probe. You need to be calibrated to do that. You need 25 grams of pressure with a standardized probe. And tonight, you have the opportunity during the break. There is an analytical balance at the back. There is a probe and there's a model. And you can test to see how much your probing is. And in the past, we've done this, and no one's going to watch. You're going to do this. This is a safe space, right? Yeah. We've had ranges from 5 to 400 grams. Yeah. So I can tell you that 5 grams to 400 grams, you're going to get a different probing depth, guaranteed. So this.
And even more so around implants, where you're also maybe navigating some really interesting contours subjectively with the emergence from those implants. And we're supposed to be even more delicate with that, and still have a huge range.
Yeah. So you need to probe. You need to probe around teeth. You need to probe around implants. You can use a metal probe for both those. Okay. So if someone tells you don't probe around my implants, there's something wrong with their implants, right? So you have to probe around these things. 25 grams. You want a cylindrical probe. We use a UNC 15. We have the same probe everywhere in the office. Everyone uses the exact same probe. Occasionally I'll find a probe that was a UNC 15 that's a UNC 10 now, because someone snapped the tip off it, closing the kit when they're mad, when they're sterilizing the thing. And I know as an assistant now that when I was an assistant in Uganda, that putting those kits together it's hard work, okay? Because you can damage stuff really easily, especially those delicate little probes. The tip, the diameter, 0.6 millimeters max, and the flare on that about 1.75 degrees. So Hugh Freedy is the one we get our probes with. You can use whatever probe you really want, but make sure you have the same one in your office that everybody uses. It's like having a tape measure that some are in metric, some are in imperial, and some of them are stretched, right? So it's not helpful to have that because you want to always compare the same. And the electronic probes, so you can have these, it's called the Florida probe, I think, that you put your foot down and it probes for you, and then it gives you a measurement. And if you want to spend an hour probing, that's for you, right? But it's really not really necessary. You should be able to be doing the probing manually, and for now, this is the gold standard. I'll give you a preview of what I think is going to happen at some point with the technology that we have. I think the probing may eventually, the gold standard may turn into a CBCT with an AI analysis of where the radiographic bone loss is compared to the CEJ. Because that can be done with a CBCT, which is the equivalent of 2 dental x-rays, and it can be done automatically, right? So, and that would save you probing the patient's whole mouth, right? And the variation and around the bulbous crowns and the ouch, this hurts, and I ran into a calculus shelf, and so this is something that I think is going to be, this is what's next. What that won't tell you is the bleeding on probing, right? So the bleeding on probing, it's the absence of bleeding on probing that's really helpful. So the fact that when you probe and it's not bleeding, that's a really good sign. Either the tissue is healthy, or boy, that patient smokes a lot. Right? That's another thing that can mask it. Anticoagulants can also increase the bleeding on probing. And you can do it bleeding on probing 2 ways. You can either be a dichotomous thing where it's yes or no, like there's bleeding yes, bleeding no, or you can have a line of bleeding if you want to record that. We don't do that here. We just do the points, the individual points of bleeding. And the probing depth in health is, of course, less than 3 millimeters. And the standard of care is a full mouth probing with probing depths at 6 sites per tooth. And here we do that every visit with every patient because they're perio patients. You may have a different philosophy in your clinic, and if you have a healthy 16 or 17-year-old or someone that hasn't, I don't think it's necessary to probe them every visit, but they should be probed at some point that you feel comfortable. So, any questions or comments about this? Have I gone offside anywhere yet? It's still early, right? Okay. No? Good. We'll keep moving. Radiographic features of health is the lamina dura is both laterally intact and at the alveolar crest. So we see the lamina dura, we can follow that around. There's no evidence of bone loss, especially in the furcation area, so there's no visual bone loss. The critical distance is a 2 millimeter distance from the most coronal portion of the alveolar crest to the CEJ, and about 1 to 3 millimeters is reasonable. A little bit more in the maxilla than in the mandible. And tooth factors. How old is the patient? What's the tooth type? Is the tooth angulated? Because you're going to have a greater amount of clinical attachment loss or radiographic bone loss on the distal of a tooth that's really tipped than on the mesial of that same tooth. So you got to take that into consideration. There has to be a certain amount of reasonableness, as they say in law, with this assessment. And severe attrition can also influence the CEJ-AC distance. Right? So anything you'd like to add to that, Louisa?
The quality of the radiographs is really important.
Yes, right.
So if you can see how fine that lamina dura is, if your radiographs are not of a good quality, you're not going to see that. If your radiographs are taken and the teeth are tilted, or the patient has like a really shallow palate and you can't quite position the radiographs the way you want, and everything is at an angle, you're not going to see the features the way you would want to see them.
Yeah.
So,
Is everyone using digital radiography now? Yeah. Yeah. Good. Good. Yeah. So that's great. We've been experimenting a lot with Diagnocat and some digital radiography programs. We're still working on those. They're going to be helpful, but we're doing the heavy lifting with that, and we're sort of prototyping that. Targets. So you want to maintain periodontal health over a lifetime with no adverse changes. That's great, but you've got 95% of the population that has gingivitis. Right? You go to a first-year dental school class, you look and see who has pristine health. Nobody does. Right? So it's just not something that's there. It's really only 5% of the population that's not affected by this. And unfortunately, 60 to 65% of the population in North America over 65 years and older have chronic perio from the old definition. Right? That's a lot. Right? And with the new health changes with the new administration, who knows how many more of that, but where that's going to change, right? So anyway. All right, so we've got periodontal health and gingival health. Ticked. We're happy, we're comfortable with that. Any questions about that at all? No? We're good, we know how to spot healthy people, right? Okay. Next up, gingivitis, dental biofilm induced. So the questions that are often asked is, does pristine periodontal health exist? And if pristine periodontal health exists, is it a normality? And as I just mentioned, it's not a normality. But there's a biological level of inflammation in the new guidelines that they say is consistent with clinical health and homeostasis. So they said a little bit of bleeding, less than 10%. That's probably we'll call it not perfect, we'll call it normal, right? So that's still good. But more than that, the patient's going to start to report these symptoms, and the words that we put to them are bleeding gums, pain, halitosis, dysgeusia, difficulty eating, red swollen gums, something doesn't look right. Usually they kind of figure out something's not right. It's sort of the bleeding is really one of the giveaways that they have. Sometimes the swelling, sometimes it just doesn't taste well. I'm going to put my hygienist on the spot. I know Donna loves to be on the spot, and I'm going to ask about what the most common gingivitis complaints or symptoms that patients present with. What do they mostly report?
As I'm sure you all agree, bleeding gums is definitely what they notice. But I've had a lot of patients come back, the 65, 70-year-old man, and he comes to me and he's like, Donna, I need your help because my wife says I have bad breath.
Okay.
Right?
Yeah.
You have that.
Yeah, fantastic.
Yeah.
Yeah. Kath, anything you'd like to add to that?
I had a patient today who just said that her gums were feeling sore, and she says, I always know when it's time for my cleaning because I can feel my gums change. And so
Yeah.
a little bit of inflammation, and they're just a little more aware.
Okay. Thank you for that. So clinical characteristics common to plaque-induced inflammatory gingival conditions, so these are clinical clues, are confined to the gingiva. So the inflammation is confined to the gingiva. There's no bone loss that happens. There's a high bacterial plaque burden to initiate the inflammation, usually. Yeah, usually there's a high plaque burden. The attachment levels on the periodontium may or may not have experienced a loss of attachment or alveolar bone. So as soon as the alveolar bone is going, then we know that it's sort of progressing. You're down that one-way street. Swelling, seen as a loss of a knife-edged gingival margin. You see blunting of the papilla. Bleeding on gentle probing. Right? This is why we have the analytical balance, gentle probing, not 400 grams of probing. And redness, and I'm not sure I agree with this one, discomfort on gentle probing. You know, there is that I would dispute a little bit. And since the recommendations have come out, there's been a really interesting paper published that's used the correlations of a really big population study. So they've looked at, I forget which population was, N. Haynes or something like that, but they were able to correlate that patients that have a low pain threshold, which is measured by, they put a band around your arm or your leg, and they squeeze it and to a certain point, and then if you are able to withstand the pain, then that you have a high pain threshold. But if they just sort of touch and go, ooh, that's really sore, ooh, that's really bad, right? That's a low pain threshold. So they were able to correlate this large population, the patients that had a low pain threshold, with a higher amount of periodontal disease.
Isn't that related to anxiety too? I mean, it's relative because some people, before you even touch them, they jump, right? So they say, I have really low pain threshold. Well, I barely touched you. So.
And now you try to do a thorough debridement on them, and then good luck, right? So they maybe get a more superficial debridement than they've had before, and they choose the provider that is the most superficial, and they say, you know, she didn't hurt me, he didn't hurt me, I'm going back there. This superficial debridement happens, and then the cycle goes over and over again, and before you know it, you know, you have developed a situation, right?
And
So.
they're not touching their gum line with their toothbrush either because it's a little bit sensitive.
Yeah, that's another part of it. But this pain threshold and sensitivity in periodontal disease, that was something that was really interesting to me, because we get kindly referred a lot of patients that take exceptional management that have extremely low pain thresholds, and you know, we just have to freeze them for every visit because they're so sensitive, and they've got 3-4 millimeter pockets, 2 millimeter pockets, and like, you really want me to freeze your whole mouth? And they're like, yeah, we have to do that. I'm like, okay, well, you know, good for you that you know that you need to have this done. But on the other side, it's like, okay, this pain threshold is not really, this isn't typical. Yeah,
Do you know
Aurora.
that there is any correlation with like increased low pain threshold with depression and anxiety medications like clonazepam, and you know, they take this, like I only take a sleeping pill, okay, that's clonazepam, you take 2 at night,
Yeah.
and you're telling me that you're taking 4 clonazepams a day. Holy smokes. So
Yeah.
anxiety must be through the roof.
Sure, there's, you know, especially we have, and Eric, in your practice as well, with fibromyalgia patients that go through those waves, that they have times when they're really great and then when they're really low. And I always ask, are you in a trough or at a peak with your situation? And if they're feeling good, we're going to get a lot further than if they're down, right? So, but it's something that's a cyclical kind of situation. I don't know if you want to add anything to that, Eric, or that's what you see in your practice as well. And this isn't, I'm going to put everybody on the spot today because no one's going to come back. But
Well, yeah, I mean, you see it with that. You'll see it with other chronic disease issues too. They'll go through troughs to peaks,
Yeah.
and the same thing will happen. And you'll find that even with restorative, same thing happens. You manage it great one day and not as well the next.
Yeah.
So for sure.
Yeah, that's a totally different level when you have to do restorative on a patient, because there's so much more noise and equipment and the length of time, and you can't bail on it once you start it, right?
Right.
Yeah. So,
And
all right.
I just was
Yeah.
thinking when you mentioned the antidepressants, and that's causing dry mouth as well. So
Yes,
it's
that's
your
Yeah, and with the dry mouth, we don't have the lubrication, and then we have the
Increased inflammation.
increased inflammation as well. So less buffering capacity, that sort of thing. And then we have other modifying factors, so systemic disorders, which we just talked about, and drugs, which Donna just alluded to, which can alter the severity of the inflammation. And then the reversibility of the inflammation by removing or disrupting the biofilm. So removing or disrupting the biofilm is really critical in reversing this situation. So this plaque-induced inflammatory gingival condition, you've developed this slime layer like you have on the inside of a fish tank, and you need to agitate that somehow. And for those of you who've cleaned a fish tank, you know that you drain the fish tank, you shoot a hose at it, it's not going to do it. You need some detergent, you need some agitation of this film. Well, that film, or the film on your tray when you're going to a cafeteria, that biofilm that's on that tray is something that you need to disrupt by physical agitation. Yeah, so to have a gingivitis, you need to have more than 10% of the sites according to the new guidelines. So that's given us like, okay, there's a reprieve. You don't have to be perfect, which is great to hear for us as dental professionals, because we're trained that we have to be perfect. No probing more than 3 millimeters. And the situation of gingivitis is usually completely painless, and it rarely leads to spontaneous bleeding, but it's subtle little clinical changes that are noticed over time. And most patients are unaware of the disease or unable to recognize it. They just think this is a level of normal, which you can't fault them for that. And defining a gingivitis site is much different from defining a gingivitis case. What do you think we mean by that? Right, so instead of labeling the whole patient that they have gingivitis, we have these sites that are like that. Right, and thank goodness it's completely reversible. We figured out how to cure that. It's completely reversible, and once the dental biofilm is removed. And there's a number of ways that we remove biofilm, which we're going to be getting into, and that's one of the things that Kat's going to help us with as well, to tell us how we do that with our brushes and our case. And gingivitis case is graded and identified using bleeding on probing scores. So we'll move on.
I just had a little thought.
Yeah, please.
Fritz,
Yeah, please.
When we talk about 10% of sites, the way that we do it is, let's say the patient has 28 teeth, you've got 168 sites. So if you want less than 10% bleeding, you can't have more than 16 bleeding sites. That's not very many.
Yeah.
Right?
Yeah. So,
Out of 168.
yeah, it's a good point. So the extent, we have this incipient gingivitis, localized gingivitis, and generalized. So if only a few sites are affected, it's a mild redness, broken line of bleeding rather than edema, or an immediate unbroken line of bleeding on probing. It's an incipient gingivitis. Localized is more than 10, less than 30, and generalized is more than 30%. So these are sort of the parameters that we have for gingivitis. And we have severity. It's mild, moderate, or severe. And for this, they really don't have a way of measuring it, but they have a way of describing. So mild is a minor change in the color and little change in the texture of the tissue. Moderate, we have glazing, which I love that word, that the tissue is glazed, right? It's red, it's edematous, it's enlarged, and there's bleeding on probing. Right? You think about some of your teenage patients that are more susceptible to that, which is a combination of things. And severe, areas of overt redness and edema with a tendency towards bleeding when touched rather than probed. You see the distinction between the touched versus the probed part, right? So that's really an interesting but subtle difference. So I think we're getting into really the nitty-gritty of this, which is why I'm a periodontist. But I think what you would probably be good to know is that localized versus generalized, 10 to 30 or more than 30 with no attachment loss or bone loss. Good. Any questions or additions before we move to the next? We're good? We'll keep going. So here's a very handy chart, which is the difference between health and gingivitis. So both of them don't have any attachment loss, The pocketing for both, assuming no pseudopockets, is less than or equal to 3 millimeters. Bleeding on probing is less than 10% in health, but in gingivitis we have more than 10%. And both of those have no radiological bone loss. Yeah? So this is how we quantify that. So local risk factors, predisposing factors, dental plaque biofilm retention factors, so tooth anatomy and restoration margins, those overhangs. Oral dryness also, like Donna mentioned, if you have decreased saliva flow or decreased saliva quality, that will increase your risk factor. And then systemic risk factors, smoking, metabolic factors, vitamin C deficiencies, certain medications, many medications, taking a number of medications together even will change that. Hematological conditions, sex steroids, these things will change your susceptibility to biofilm-induced gingivitis. Local exacerbating plaque-induced gingivitis, so prominent subgingival restorations, right? Hyposalivation, I think this is one of Donna's patients or Kathy's patients. And then dryness makes the plaque control even more difficult, and the inflammation may be worsened. And it's a symptom caused by a lack of saliva. It's not a diagnosis. Okay? So xerostomia, not a diagnosis. It's a symptom. And so how do you guys treat patients that come in with the symptom of xerostomia? What do you do for them? What works all the time? Nothing. Okay. What works some of the time? So does biotin help these patients? Sometimes, maybe a little bit. Yeah. Right, yeah. Yeah, so we're looking for answers as well. Right, the xylomelts, yeah, those sometimes are helpful. It's so frustrating as a clinician to have a patient that has xerostomia, which affects their life so much. And you're like, well, it's just a dry mouth, but it's not. It really affects them a lot, right? And you're like, well, what can we do to really help you with this? And it's frustrating. So we'll be delving into that a little bit more in a future lecture. Systemic risk factors, and I've starred what sort of how important it is. Hyperglycemia is really important. And children with type 1 diabetes, the level of glycemic control is more important than the quality of the plaque control, if you knew that. Medications, there's a whole list of medications, antihistamines, decongestants, and they can progress to not only gingival conditions, but dental caries, taste disorders, halitosis, inflammation. Smoking is really a big one, right? Smoking is really a big thing. Plaque accumulation and disease progression is much higher in smokers. Smokers have fewer clinical signs. And if you remember back to one of the lectures we did after we came back from Sweden in 2006 or 2008, we learned there they did a study and that smokers spend 67 times more on dental work than non-smokers over their lifetime. So I thought that was a really interesting stat, that they spend that much more on dental. And I think about my patients that come to see me for reconstructions and that, and many of them, most of them have a smoking history. Dr. Schultz? No, okay. You're just pulling coconut out of there, okay. Got it. And then malnutrition, obesity, and vitamin deficiencies. Yes, scurvy was a real big problem for the polar explorers, right? So they lost a lot of their teeth for polar explorers. The Vikings, on the other hand, they didn't have the problem with scurvy. And the reason was sauerkraut. The Vikings traveled with a lot of sauerkraut, and they avoided scurvy with that. So, fun fact, okay. And there you go. Puberty, as well as increases plaque biofilm levels, dental caries, mouth breathing, crowding the teeth, tooth eruption. My son, when he was 13, he lost his mind, and he's 19 now. He's sort of getting it back, but I think it could still be a few years. So yeah, there's some decisions sometimes that kids make that are questionable. But a lot of these dramatic rises in steroid hormones have an effect on things and affects both genders. Pregnancy. During pregnancy, the prevalence and severity of gingivitis has been reported to be elevated, unrelated to the amount of plaque present. So we have the surge of hormones, which happens. And gingival probing depths can be deeper. Bleeding on probing or bleeding with toothbrushing is sometimes increased. And I don't know if this is just because of being nauseous and not being able to clean as much. So I'm not sure how much of this is anecdotal versus done. But one thing that we do see here is an increase in pyogenic granulomas. So we often see these pyogenic granulomas or pregnancy tumors in patients that are expecting, usually near the end. And this is one right here. And they look really frightening, right? These things come up really quick. They're very vascular. And you think, boy, I've got this tumor here, and like, what do you do? And it's like, well, we'll take that off later if it doesn't go away on its own, right? But how many of you have seen a pyogenic granuloma? Yeah, cool, eh? Yeah. All right. So the update in 2017, it used to be that oral contraceptives were associated with more gingival inflammation and gingival enlargement. But this was they couldn't bring this they couldn't correlate this, so they've reduced their stance on that. And then for menstrual cycle, although some women are extremely sensitive to changes during menstruation, most women have no detectable signs of the condition during that time. So that was another part that seemed to be there wasn't a lot of great evidence for it. So that's a bit of an update too. Oral hygiene. We like to say frequency does not take the place of thoroughness. You can quote us, Kat, okay? And so the frequency does not take the place of thoroughness. So we need a good combination of good oral hygiene and thorough, regular professional care. Right? You can't do it all yourself. Plaque accounts only for 20% of the direct risk of developing periodontitis. You'd think it's higher. But 80% of the direct and indirect risk and modifying factors may be responsible for the development of disease. So this on the far right of your screen, oral hygiene remains the most important factor in obtaining and maintaining periodontal health, but it should not be the sole focus of attention. Okay? And I can tell you, yeah, please, Aura.
I wanted to ask, I don't know where I read it, but they've seen, it was a study that was done that mouth rinses, people that use the mouth rinses, they noticed more inflammation than people that do not use the mouth rinses. Do you recommend mouth rinse at the end, or better the floss, the water pick, and the...
Yeah, so we don't recommend the rinse. If you want to use it, that's great. It doesn't replace anything. The water pick is also something that we don't typically recommend. So we always recommend a rechargeable toothbrush, right? And we don't say it's an electric toothbrush because people are worried about they're electrocuting themselves. We don't say it's a powered toothbrush because they're worried they're going to scrape their gums off. We say it's rechargeable because it's contemporary and it's sustainable. We also advocate interdental brushes, flossing, but we don't. The water pick and that is something that if you want to use it as another adjunct on top of everything else you're doing, go ahead. It's not going to do any harm, but it's not a frontline thing. So that's sort of our stance on it. And Kathy is going to make it.
I just want to say that often, as far as the water pick, I say for people that have braces and have food that's trapped on their braces, it's great for that. But it doesn't remove the biofilm. So you still have to do your whole oral hygiene routine, and that's just extra time. Something, if it makes you feel good, it's not going to hurt anything.
Yeah. And if you've got a big ugly flange with the implants holding the flange in to get underneath there, I guess you're going to do it. But yeah, we're not a huge advocate of the irrigation or the blasting that in there. It's easy to do and but it's not as effective as the other. So, but great point. Thank you for that. So the biological model for health to gingivitis, it's health to disease. You have these plaque levels. There's early plaque accumulation, heavy plaque accumulation. The elephant goes across the bridge and the bridge snaps, and then you have disease, and there's no going back with that. With gingivitis there is, with periodontal disease there isn't. And that's where this slide comes in. It's a two-way street between gingivitis and periodontal health, but it's a one-way street from gingivitis to periodontitis. And I lost an S there somehow, so I'm going to fix that. Large variations exist. So the extent or intensity will vary very much between patients, as it will among sites within a dentition, right? So sometimes people are very good at doing certain areas, but completely don't touch another area. And it's only when the hygienist or the dentist says, look, you've done this. Like, why are you missing this? And it could be a dexterity issue. It could just be something, an oversight. So one of the things that we love to do is use disclosing agents. Right? And I don't know why we ever stopped using disclosing agents. They're so useful. Maybe because they're messy and it takes time. That's probably why. But they're really helpful with showing patients where they're missing. And we talked about the common clinical features, and the severity is influenced by these factors here. Moving forward. So we have inflammation is natural, and it's an important defensive process in the body. So completely suppressing inflammation isn't useful either. And it's really it's important because not all sites progress to periodontitis. It's an inflammatory process that's protective, and the plaque accumulates more readily at inflamed sites than non-inflamed sites, creating a complex dynamic. And you've all seen that. You've had a patient where they don't want to touch an area because it's red and bleeding, and then that creates a cycle where that keeps building up, and then all of a sudden they're like, I don't know what to do here. So what's the first thing we do? We touch it and disrupt the biofilm and make it better, right? Okay. All right. So we've knocked down gingivitis dental biofilm induced. And we have gingival diseases non-dental biofilm induced. And Dr. Schultz is going to jump in on some of these here because she's really great with these ones here too. So non-plaque induced gingival diseases, they're less common, but often really significant. So you got to figure out these outliers, right? Because you can't paint it all with one brush. And sometimes they're manifestations of systemic diseases, which we'll talk about. They may represent pathologic changes limited to the gingiva, and it's based, the classification, what's important is it's based on the etiology of the lesion, not somebody's name. And there's 8. There's 8 categories of non-plaque induced gingival diseases. And we're going to go through these with examples. Okay? All right, so fasten your seatbelts. We're going to head to this next slide here. Number 1, genetic developmental disorders. So we have hereditary gingival fibromatosis. That's this young patient here. He came in and he had this complete overgrowth of the tissue and then this bleeding red, shiny, glazed area. But it was a genetic condition. So there's no amount of brushing or flossing or water picking that's going to help with that because it's genetic. So we had to surgically reduce that and then monitor and make sure that we keep up with his maintenance, and understanding what the etiology is important. Other rare diseases, again, the son of a 7-less gene, which is not very helpful in diagnosis. Specific infections, this is a periodontitis, not a gingivitis, but you can have a necrotizing periodontal disease. We're going to be talking about necrotizing periodontitis. But you can have ulcerations on the gingival margin of bacterial origin. It can be an infection that's viral, or a fungal origin, which candidiasis is the most common. Yeah, please, Bernie.
I have a question. Going back to the gingival fibromatosis, how do you know that that's that? How do you figure it out that it's that and not plaque-induced?
Biopsy. Yeah, yeah. So you kind of suspect that this is it. This patient was, I think, 9 or 10. Tissues were like absolutely overgrown. He wasn't taking any medications that would have done that, so any medications that would have done. So we have this overgrowth of tissue, atypical in this dark-skinned patient. And so we're like, okay, we're going to trim some of this away, and I'm going to send it off. And we sent it off to Mount Sinai, and it came back as this with the history. So that's how the definitive diagnosis is made with that. Yeah.
You would expect there to be plaque there too, because it's so swollen that,
Yeah.
Right?
And often there is lots of plaque with it because it's uncomfortable to brush, and you can see the plaque just sitting there. So that doesn't help. It just accentuates that area. Louise, anything you want to add to that? Yep.
Really great points. Biopsy is a really important part of a lot of what we do. So tissue that's removed from the mouth that we're not sure what it is should always be sent in. 90% of the time we'll find out it is benign and nothing more to worry about, but it's really comforting to be able to get that information with accuracy to our patients. Unfortunately, we do get some more serious conditions every so often, and the sooner those are caught will have a huge impact on the patient's outcome. So whenever in doubt, we are very happy to do whatever biopsies are necessary.
Yeah, standard of care is you have to determine normal versus abnormal, right? It's normal versus abnormal, and then if you don't know what it is abnormal, we got to put a name to it. So that's when you refer to a specialist, and the specialist has to give the name of what this is with a really high level of confidence. So that's why the biopsy just isn't, the specimen isn't put in the bucket and we say, yeah, it's probably a papilloma, because every now and then the papilloma has had some mutation. I had for the first time last year, I had a patient who, I've been doing the tongue exams, I've been catching a lot of stuff with tongues. I've been doing the floor of the mouth exam where I put my finger in and palpate, and for the first time in my career I found a lymphoma, so on a patient. So it was a raised floor of the mouth. It felt like he had a Tootsie Roll in the floor of his mouth. And so I'm pressing on this, and I'm like, this is really odd. Yeah.
Uneven, right?
Uneven.
Really
It was.
checking that one side of the floor of the mouth is much higher than the other.
Yeah. So yeah, but that's for another day. Inflammatory and immune conditions, number 3. So hypersensitivity reactions, contact allergies, plasma cell gingivitis, erythema multiforme is another hypersensitivity reaction. Autoimmune diseases, so we get a lot of these, pemphigus, pemphigoid, lichen planus, lupus, but the most common is lichen planus, right? So, and the relief that some of these patients have when they're diagnosed with lichen planus, I've had many say, you know, for my last 20 years, I've been told that I don't brush my teeth properly. You know, I've been nagged that I'm not brushing well, and I'm brushing as best I can. It just really hurts to brush. And then they get a diagnosis of that, you know, of lichen planus, and it's like, okay, so my tissues are much more fragile, and this is what the situation is. So then the management is completely different. The paradigm has been shifted, and we're able to help them more. Pemphigoid and pemphigus, much more interesting. Clinically, much worse for the patient, of course, because the patient, by rubbing on the tissue, you can actually take the surface off, and it leaves them with an open ulcer. Helps you with the diagnosis, sort of, but it's really something terrible to live with, thinking that your tissue is going to be able to be peeled off all the time. Fortunately, we have an array of rinses and steroid rinses that we've sort of improved over the years that can handle a lot of these situations, and they're titrated for the patient, and it's a bit of an art to do that, but it's been one of the things that we've been really able to help patients with pemphigoid, pemphigus, and lichen planus. And the best is if they can get it on without these steroids, because like it's kind of like if you have an eczema or psoriasis and you need a steroid cream.
It thins it out the tissue even more, right? It's a vicious cycle.
It can thin it out, and also it turns into a job for them. And we don't like to use the Kenalog and Aura base to put that in the mouth. That just it's a punishment for the patient. So a rinse is there, and there are steroid injections that you can do as well. We don't do those too often, but that's another thing that's possible for these patients. And then we have granulomatous inflammatory conditions like Crohn's disease. So if you have a patient that has Crohn's, look very carefully at their gingiva, because quite often the condition that's affecting the integrity of their gastrointestinal tract doesn't stop, at their esophagus. It's in their mouth as well, and you can often see the oral manifestations of that. Louise.
We are going to talk a little bit more about systemic and oral health a little bit later, but patients who have one autoimmune disease, it's very common for them to have others, and some of these also have manifestations on the skin. So we've got our derma friends next door that can help with those, but it is really important to look through the whole medical history. Remember, you had a really interesting case as well that had odd ulcers, and just in the discussion going further with her, you were able to diagnose a more complex condition that she had.
Yeah, and this is going to change the way that we approach diagnosis as well. And later on in the series, I'm going to show you how we are able to take a medical history, de-identify it, run it through an AI program, and say, what questions should I be asking about this patient's health? Right? What do I really need to know about this patient? Or I'm going to do surgery on this patient, what questions do I need to know, or what modifications should I make? So we're doing this already, and it's phenomenal, the insight that it gives you and the blind spots that it shows you. So that'll be some of the upcoming things. Reactive processes. So this is an epulus here that you can kind of see the red finger-like projections. Like if you're looking at it under a microscope, it kind of, you can see the capillaries there. And this is something that is quite interesting. This does not resolve on its own. It needs a surgical removal. And with a young patient, you have to go into the gingival margin. It gets sometimes tricky. So in the hands of a periodontist, this is something that is pretty routine because we're used to repositioning tissues. Also, with the patients that are kind of afraid to brush this area, you can see the plaque. Neoplasms, premalignant and malignant. So we have leukoplakia and erythroplakia. And then malignancies on the gingiva, squamous cell carcinoma, leukemias, lymphoma. As I mentioned, we just saw the lymphoma. You're looking at a palate of a patient that came in and couldn't put his obturator back in. So that was a job, I remember, for one of our hygienists to put the obturator back in so that he could eat his lunch. Right? So that's how we roll around here. Endocrine, nutritional, and metabolic diseases, vitamin deficiencies, scurvy, vitamin C deficiency. We've also learned, since the guidelines have come out, how important vitamin D is. Okay? So my team is probably sick of me asking patients about vitamin D, but it is really one of the elements that explains why sometimes implants fail in an otherwise healthy patient. So you have a patient that's not a smoker, not a diabetic, patient's perfect in every other way, surgery goes really well, and the implant doesn't integrate. And you're like, why did that not work, right? So generally that unknown category is due to a vitamin D deficiency. So what we're doing for most of our patients now is we're having them on 2,000 units of vitamin D generally. But in anticipation of an extraction and an implant placement, we will almost insist that they take that, because in a study that we did in our clinic many years ago, for patients that come in for perio, most of them were deficient from vitamin D. So,
Has something to do where we are located.
right.
A little bit further north.
Yep.
Dark winters, lots of snow, not as much vitamin D.
Yeah, if you're under any of the maps where Louisa is, from Australia and Africa and the South Pole, there you have lots of sun. But here, not so much right now. Yeah, there was a hand up.
In
Donna?
that study we did, Peter, I remember that it was deficient, insufficient, and sufficient.
Yeah.
And the only patients that were sufficient were on a supplement. There were
Right.
none that, yeah.
That is an excellent point. Yeah, excellent point.
That's where I was convinced, and
Yeah.
my whole family.
Yeah.
And they still got vitamin D in their stockings this year.
Yeah, yeah, and at that point when we did the study, I don't know if that was about 10 years ago now, probably just around that, it was actually a blood test that you had to do, so we had to draw blood to take it, and it was over $100 for the test to do for our patients, and we did that through a research study. But now there's a chairside test that you can do with a pinprick that you can do with a lancet. So Robert Miron from Byrne University, who's now in Florida, they've put together this kit that you can do. So a chairside test.
Yeah,
So.
because it's still, you have to ask your doctor and
Yeah.
pay for it.
Right. Yeah. Eric.
Just something that I did years ago. I did the vitamin D test for years, 15, 20 years ago.
You were such a visionary. Yeah.
Back then, I was taking about 5,000 units a day.
Yeah.
And I did that for about 3 months, went back and retook the test. And I still didn't quite make that low end of the range. It takes a while
Yeah.
to build it up. It really does.
Yeah. Absolutely right.
The benefits are multitudinal. It's not just our oral health or implants, right? If we could push away needing all those bisphosphonates, prolia, all those other medications because our skeleton is that much healthier, our bones are healthier, and our teeth are healthier, that's wonderful.
Yeah. You know, remember when COVID, one of the correlations they did was a vitamin D deficiency for patients who did worse with COVID. So, see, that's why I like Dr. Mullins. You see, he's a visionary. I'm just a peripheral visionary. I only see things from the side, but he sees it well in advance. So, great. Thank you for that contribution. It's fantastic. Yeah. Traumatic lesions. So, self-inflicted, iatrogenic, accidental injuries. Get those a lot. Frictional hyperkeratosis, toothbrushing too hard. A lot of the times, though, it's sharp cusps and things that are pushing against the cheek and the tongue. And one question I've learned to ask now, if I see a patient that has hyperkeratosis on their tongue or their cheek, I'm like, which side do you primarily sleep on? And if we can replicate how you sleep, then you're pushing the cheek into that area. It sometimes helps shed light on how that positioning might happen. It doesn't happen with the gum so much, but just overall, it's a little tip that we have. I had a patient in just today who was rubbing Oragel on a tooth that was on the gum on a tooth that was sore, and created a wonderful ulcer that was about 1 centimeter by centimeter with sloughing tissue on the gingiva. So we see that from time to time. People rub still ASA and they grind up Advil or Tylenol and rub that on the gum. Just whatever you get from the research you do on entertainment platforms. And then there's always microwave heated foods in coffee shops that have that. I didn't have a delicious pizza on here. Yeah. So
Cheesy pizza.
yeah, delicious pizza. It's never just regular pizza. It's always delicious pizza because you have to make it sort of worth it, right? Yeah. All right. And yeah, so we have sometimes oral piercings and that. So. All right, and number 8, gingival pigmentation. So, so the pigmentation can be exogenous or endogenous from melanoplakia. So we can have things that are put in from heavy metals, from Addison's disease. Sometimes you get these things. Smoker's melanosis in the mandibular anterior facial gingiva, and that goes away if people stop smoking quite often. But any sort of dark pigmentation in the gingiva or in the mouth needs to be explored, right? Because you're worried about a basal cell carcinoma. That's what the differential is. So any sort of dark area, unless you can explain it, it needs to be verified. Drug-induced pigmentation, I haven't seen a lot of that. Amalgam tattoos, though, we see a lot of those. Sometimes you can if it's on the floor of the mouth or something like that, a dental radiograph can pick it up, and you can see the little bits of debris. An amalgam tattoo is, but you want to verify that it's actually that, because the basal cell carcinoma, you don't want to miss that diagnosis. And every now and then you see a real tattoo on a lip or on a cheek or that. How many of you have seen that? Yeah. Okay. All right. Yeah. So that's fashionable. We have a tattoo removal situation now in the dermatology clinic. So I don't know if they do those types of tattoos, though. That would be.
Pretty sure they can do anything.
Yeah. Yeah. Okay. All right. So yeah. So to review this, a patient when you're thinking about gingivitis, it can be localized or generalized. And a patient with a reduced periodontium has a history of periodontitis, and it's bleeding on probing more than 10% is diagnosed as a gingivitis case, localized or generalized. Treatment is pretty easy. Patient motivation, oral hygiene, professional mechanical plaque removal, and adjunctive use of antimicrobial or anti-inflammatory oral care products. And if only we had someone to talk about that here. If only we had someone to talk about antimicrobial oral care products. Also, well, stay tuned, right? I'm setting you up. Dietary advice, tobacco counseling. Tobacco counseling, we're anti-tobacco here, just to be clear. One of the things that we're bringing on board here, there's a book that's helped so many of my patients. It's Alan Carr's book. Do you know this book? It's a book that you actually, you smoke while you're reading the book as a smoker, and then it weans you off the smoking. And I always frame it that if I have a patient who I can see is sort of fairly logical, this might work for them, right? So Alan Carr's book on how to stop smoking is really a useful tool for them. And we're going to be bringing it into in our minor bookstore where we have Adam Schultz books, and we'll have these non-smoking books. Malcolm Gladwell has a chapter in one of his books on smokers. Have anyone read this? He talks about how you're imprinted to be a smoker when you're young because you see somebody who's really cool and you want to emulate them, right? And they ask, who do you see who is a smoker? And you think about, oh, my cool grandpa, or my cool aunt. And it's someone that's really has some sort of personality that's resonated with you and that sort of has given you the psychological tie to it. So I love the line that he has. He says, smokers are cool, but smoking isn't. So that sort of stuck with me. And then moving on to site versus case normal, a patient with bleeding on probing less than 10% without loss, attachment loss, is considered clinically periodontally healthy. And that's where, of course, we all want to land if we could. And that's another gem we have here. So I think at this point, there's a good moment for a break because it ties into the mechanical plaque control. But let's take a 10-minute break. And please visit CAT. You can also try the probing and enjoy some more snacks. Grab another coffee if you like. And we'll reconvene in about 10-15 minutes. Does that sound okay? All right, cool. This is a way that I think about periodontitis. When I have a patient that comes in and they've got periodontal disease, I use the acronym SLEET. SLEET is the acronym that I'm thinking of. I'm thinking of things that are systemic, lifestyle, environmental, epigenetic, or tooth factored, right? And some of this is going to be, there's going to be some combination of this that's responsible for their periodontal condition. So let's go through that. So systemic disease, so either the patient is an uncontrolled diabetic, they have some autoimmune condition, there's some sort of systemic weight that's happening with that. There could be a lifestyle issue. There's an individual variation in their oral hygiene, their smoking, their diet, their stress levels. So there's a lifestyle component. There's an epigenetic part. There's a variation in their gene expression and just how they've been born with genes that make them susceptible to periodontal disease, or how the immune system is working. Environmental, individual variations in plaque and subgingival biofilm, the microbiome. So environmental, or tooth factors. So root anatomy, dental restorations, tooth positioning and crowding, pocketing, iatrogenic and occlusal forces and functions. So I always look at SLEET, and I'm always thinking about that. And when the guidelines came out, and when I heard about this, I'm like, this is really fantastic, because it then weighs it weighs on how you form your diet or your treatment plan for your patient. And those of you that have seen my new patient and Louisa's new patient general letters, we always have a circle, a pie chart, that says we think that the periodontal condition is this much epigenetic, this much environmental, this much systemic, and that allows us to target on those areas. So it's never just one of these things, it's always a combination of systemic, lifestyle, epigenetic, environmental, or tooth factors. So if you only remember one thing, it's SLEET tonight. All right, going to necrotizing periodontal diseases. This is like the disgusting part of perio, which you're going to like. So there are 3 hallmarks: papilla necrosis, bleeding, and pain. Right. So this is how it is. So this is, and those of you who've been to my lectures before, I love this case. This is a patient who I diagnosed from the waiting room. That you could just smell them. I didn't have to see them. It was like you almost do, like you couldn't do it online, but almost. So they came in and they had this necrotizing periodontal disease. Over the weekend, the tooth fell out. They had this exposed canine. I removed it under sedation, cleaned it up. They came back with this bone defect here, which we cut away with a piezo without any anesthetic because it doesn't hurt. and then they were left with this situation there, and then they thought they were cured but left. So this is a necrotizing disease that's treated with antibiotics and surgery. I get referred necrotizing disease a lot. It's very often not necrotizing, though. It's something else. So I've only seen a couple of cases like this in my whole career. Dr. Schultz, I'm not sure how many you've seen in your career. Yeah, just a few. So, Dr. Lavoie. Okay.
Just a side note here, this was a long time ago. I think I've been working with you about a year and a half, and I was walking down the hall, and you were like, Donna, come here, go get the camera. And I had no idea, and I walked in and I took those pictures.
That's right, yeah.
Why did we ever go into burial?
Yeah, so that's what welcome to my world. Okay. So classification for periodontal disease, for necrotizing periodontal diseases. Hopefully you will never ever have to use these. This is really splitting things, but we can have necrotizing diseases in chronically severely compromised patients, and the patient that had an alcohol dependency and an autoimmune condition, was a heavy smoker. And diseases in temporary or moderately compromised patients as well. So there's a distinction there. People like to split hairs. The predisposing conditions here, are sort of HIV, AIDS, other severe immunosuppressants, and then this is sort of where my patient sort of fell in between those two things. Periodontitis in the middle, it's the 6th most common chronic disease in the world. It affects 11% of the world population, and it occurs through the lifespan. It's estimated that the global incidence peaks around the age of 38. So 38 is sort of the peak age where you have this incident. And then about 50% of Americans over the age of 30 have a periodontitis. Right? So it's very, very common. And the mean rates of progression are fairly consistent globally. So it doesn't matter where you live. It's going to go around the same way. One of the exceptions, I think, is actually in Bhutan. So in Bhutan, we don't have as much decay or perio disease because of this betel nut that they're chewing. And the betel nut has a calcium hydroxide in it. And the calcium hydroxide for hours and hours a day just remineralizes the teeth. But what they do have, and they've traded it off for the 2nd highest rate of cancer in the world, oral cancer. So so I mean that's not a great choice, but it's a very interesting population. The diagnosis of periodontitis, you need to have a probing still, and it's through attachment loss. A circumferential assessment of an erupted dentition with a standardized perioprobe with reference to the CEJ. So what confuses us sometimes is if a patient has had a class 5 restoration done, and then all of a sudden you're like, okay, where do I take my measurement from now? Like, what am I going to do? So you either decide that you're going to take it from the most coronal part of the restoration. It's hard when that changes your reference point. So the interdental clinical attachment level is more than 2 millimeters on non-adjacent teeth, or more than 3 millimeters at more than 2 teeth. And the observed clinical attachment loss cannot be prescribed to non-periodontal causes, such as exclusions. Gingival recession of traumatic origin. So they've ripped their gum in an accident. That's not perio disease. You can't diagnose them with that. The presence of attachment loss on the distal of a 2nd molar associated with the malposition of a 3rd molar. Because quite often when you're removing a wisdom tooth, you have to take a lot of bone off on the distal of the 7. And that doesn't count as periodontal disease in the new classifications, which is a really important finding. An endodontic lesion draining through the marginal periodontium doesn't count. Vertical defect fracture, a vertical fracture, also doesn't. Neither does dental caries extending into the cervical area of the tooth. So the diagnosis has been refined to these things. And the new classification is based on this staging and grading, right? And it's a personalized model. And it's something that helps determine how fast it's moving and how advanced it is. And it also takes into account the multifactorial etiology, right? There's a lot of things, like it takes into account the sleet thing that I'm telling you about. And it also helps us determine the complexity of the management of this condition, if it's going to be really easy to knock this down, or if it's something that's going to be more problematic. So in terms of the diagnosis or a definition, it's a chronic multifactorial inflammatory disease. I should put in incurable. Multifactorial inflammatory disease associated with bacterial dysbiosis and characterized by progressive destruction of the tooth-supporting structures. So, yeah, this chronic incurable disease that destroys things. And you've got this clinical attachment loss, radiographic bone loss, presence of pocketing, and gingival bleeding. I've got some examples here for voids of defects. You can see this void around here. You can see some calculus here. You can see the etiological agents in here. And the key elements of staging. So staging is kind of the severity, the extent of the loss. And it's the degree of breakdown. It can be mild, moderate, severe, but they've done this into different ways. And it takes into account the number and the distribution of the teeth. Is it localized or generalized? The rate of progression. There's direct and indirect evidence. What's direct evidence? What would you think is the difference there? So direct evidence is something that you can compare from one time to the other, right? So looking at the bone loss that you've had over, let's say, 5 years. Right? You take an X-ray time point 1, time point 2, you have direct evidence. Indirect evidence is sort of you just see them at one point in time and you're making a calculation. The complexity of management is the type of loss. So is it horizontal, angular? Is there a furcation? Is the tooth mobile? How many teeth are actually missing? It's different if you're missing 1 tooth or if you're missing 10 teeth due to periodontal disease. Right? That tells you a different story. And causal factors. Again, we're back to the SLEET acronym. So we have a handy little chart for you here on staging. And there are 4 stages. And this is on the app for you. And what it looks like is severity and complexity. And what you're looking at is the interdental clinical attachment loss at the site of the greatest loss. So you can have 1 to 2 millimeters, 3 to 4, more than 5 for these two. The radiographic bone loss, is it the coronal third? Is it the coronal third 15 to 33%? Or is it beyond that? Right? And then how much tooth loss have you had? There's no tooth loss if it's been more than 4 teeth, if it's more than less than 4, more than 5. So you look at all these things together and it helps you determine what stage this is in. Now we looked at this and we're like, okay, this is really, there's a lot to consider in here. So in our app, we've created this calculator that you can actually go in. It asks you the questions and then you can come up with the stage and grade for the case. In grading, you want to assess the future risk and the potential health impact and the ability to reverse or guide systemic monitoring. So you're looking at these 4 different things. The risk that the disease or its treatment may negatively affect the general health of the patient. You don't want it to affect the general health of the patient. So this is important that we get control of this. Anticipated inferior treatment outcomes. Well, there's something that, if we do this, we're not going to get as good a result as if we do that. The risk for further periodontitis progression and a history-based progression. So all these things you kind of look at and you determine, where is this patient going with it. Then we're looking at the evidence or risk of rapid progression. So is it going really slow? Is it controlled? Or is it going really fast? And to do that, we have direct evidence, which is if you've taken x-rays and you have time point 1, time point 2, and there's no bone loss over 5 years, we'd agree that it's not moving fast. Right? This is slow. The speedometer is going slowly. If we've lost more than 2 millimeters over 5 years, it's moderate, right? Less than 2. And if it's more than 2 over 5 years, it's going really fast. So this is sort of the direct evidence that we're going for. And fortunately, in 2018, 2019, we took full mouth series on a lot of our patients. And now we're going back and we're doing full mouth series again. And we're able to compare how much radiographic bone loss we've had over those 5 years. And we're able to adjust the staging and grading of this based on on that direct evidence, which is more powerful than what we had before, which was indirect. And the indirect was really, I thought it was brilliant when they put it out, because they had the percentage of the bone loss over the patient's age. The percentage of bone loss over the patient's age. So I have a slide that's coming up, but let's just say percentage of bone loss. You've lost 30% of your bone. And let's say you're 110 years old. Is that terrible? No. But what if you're 7 years old? Different story, right? So these extremes tell you a different tale in terms of the percentage of bone loss over your age. It's much more serious if that number is higher versus lower. Yeah, and then they put smoking in there as well. Smoking is always a heavy factor in there. And the glycemic control. So patients more than 7 are in the highest risk category. If you're higher than 7%, more than 10 cigarettes, you're in this area. The destruction is going to be obviously worse. Make sense? All right. So and here's the calculation. And I famously did the calculation at our first base camp, and I got the calculation wrong. And the next program, I brought calculators for everybody to fact check me, and the calculators didn't work. So we're going to do better this time. So how we look at maximum percent radiographic bone loss is we take the distance from the CEJ to the bone crust right here. So let's call that 4 millimeters. And then we go CEJ to the apex. That's 20. So 4 over 20 is 20%. So Pat's 102. He has 20% bone loss. Drew's got 25% bone loss, or 25% bone loss. And he's 102. He gets a 0.25. And Bill is 49. And Bill has 25% bone loss, but he's 49, so it's 0.51. So it's a bit worse. And here's Gord. Gord has 25% bone loss, and he's only 21, and it's 1.19. So you see how the indirect evidence, the calculation, is so important, that you look at the bone loss, but you also factor in the patient's age. Any questions about that? No? Okay. Interesting way to think about it, and I was really glad that they sorted that out this way. So this is a grading chart here, which is really an important slide. So it's on our app. I encourage you to look at that. And the other part that is really important for you to know as clinicians, as now really empowered clinicians, is the question of tooth mobility. So they've changed the prognosis of tooth mobility. In 1999, it was thought to be a really important predictor of how long this tooth is going to be in your mouth. It was really important. It was one of the best things that we would rely on to say, ooh, it's got this mobility, it's got to come out. Right? So it turns out that that's not a really good indicator at all. So all of you have patients where you have a patient that's got a mobile tooth, a natural tooth, and it's wiggly, and you're like, oh, I don't know how long this is going to last. I hope it doesn't come out when I'm instrumenting this. Right? Patient comes back 6 months later, still there. Year later, still there. Right? A few years later, still there. Like, how is this thing possibly staying in there? Right? The patient is comfortable, they're functional, and aesthetically, they're very happy how this looks. Right? And so you know what you do? You don't take it out. Right? You maintain it, because you can maintain these things for a really long time if it's comfortable, if it's functional, if they're happy the way it looks. So I was really happy to see that they've changed this, because the body's ability to deal with things that are imperfect is phenomenal. Right? If you have an implant that has a little bit of mobility, you know what you have to do? You have to take it out. It can't stay. Right? But you have a tooth that's in there that's wiggling, and you're like, how is this person functioning with this? And they say, I'm functioning really well. Then it can stay. So I've had a few heartbreaks over the years where I've had patients that have come to see me faithfully every 3 or 4 months, and they've got mobile anterior teeth. And they've got generally mobile teeth, but they're functioning really well. And they come in, and we check, and everything's going really well, and things aren't ideal, but they're in a happy place. And the next time they come in, they've got a partial denture that's replacing 6 or 8 teeth. And I'm like, in the words of the fantastic Mr. Fox, what the cuss? Like, what happened? And they were like, well, you know, there's a new dentist or a new associate, saw me, told me I had wiggly teeth, I needed to come out, and they made me a partial denture. I'm like, was there anything wrong? No. They said they needed to come out. And I'm like, what is happening? Like, this is really not what should be happening here, right? Now you've partially edentulated this patient, and they're stuck now with this removable appliance, whereas before it wasn't really an issue. And this has happened a few times in my career, and it's heartbreaking because you really want what's best for the patient. You want to be treated as, you want to treat people as you want to be treated yourself. And I just think don't give up on teeth that are mobile. Don't give up on teeth that have that are not perfect. So there are teeth that are imperfect that need to come out. So we have teeth that are mobile to the point where they're depressible. Right? They've got M3 mobility, they're sitting in no bone support, and the patient still is getting along with it, but you start to see separation, you start to see further bone loss, and you're like, you know what, it's time to make a call on this now, right? If it's causing harm to the patient by leaving it, that's a totally different story. Right? Dr. Schulte, did you want to add to that at all?
Yeah, just an example of the patient with the new partial denture. We now have multiple missing teeth, and we have clasps of teeth that are probably periodontally involved as well.
Yeah.
So even those better teeth are now going to have a higher risk of being lost in the short to medium term. So the more intact you keep these patients for the longest amount of time possible is really beneficial for them.
Spoken like a very important perioprostodontist. So fantastic perspective. I really appreciate that. All right. So what do I do when I want to use these new guidelines? Well, we've got that list for you as well. So step one, the initial case is you do a full mouth probing, and you need a full mouth of diagnostic radiographs. Donna's point about or Louisa's point about being diagnostic radiographs, that's important. You need to have diagnostic radiographs. You need to determine why the teeth are missing, right? Are they missing because of trauma, or are they missing because of past periodontal disease? And what was formerly mild or moderate perio is typically going to be stage 1 or 2. And the severe to very severe is going to be stage 3 or 4. So we know that. So you're going to initially overview to assess the disease. Then what you're going to do is determine the clinical attachment loss and the radiographic bone loss. So you want to rule out non-perio cases of clinical attachment loss, cervical restorations, caries, root fractures. I'd also add any previous periodontal surgery, like for crown lengthening or anything like that. That would be something to put in there. Assess the tooth loss due to periodontitis, and evaluate the complexity factors. Like, are there furcations? What's the surgical challenge that's going to be there? And then you establish the grade. You do your detailed assessment. You calculate your radiographic bone loss, the percentage of root length times 100 divided by the age, and now you know what the condition of the patient is. And you've established the diagnosis for the patient. And then from that treatment plan, you decide what's going to happen next. I'm going to stop here because this is an important slide, and I want to know if there are any questions at all. Seeing no questions, I will move on. Okay. I'll show you this case here. This patient was referred to me a long time ago for dental implants in the maxillary anterior. And she came in looking like this, and she had loose front teeth. And the referral was, please assess implant bridge 1-2 to 2-2. So I'm like, okay. So loose front teeth, need implants. This is the radiograph that was sent. 61-year-old lady, Mrs. Pancake, not her real name, to be honest. So she was referred to the drifting of these teeth. She'd noticed swelling 4 months earlier, and her teeth were moving when she was chewing. She was being maintained by her GP personally, who saw her every 6 months for a 30-minute periodontal prophylaxis. Right? No hygienist in this practice. It was the dentist doing this, the perio. She had an aortic valve replacement. She had type 2 diabetes, which was not well controlled, and hypertension. She was taking these medications here. Okay. So, treatment plan. What do we do? Oh, sorry, more measurements. 95% plaque score, bleeding 140 sites, And this is how we always stratify it. Sites measuring 4 to 6 and more than 6. That's how I like to stratify the patients to begin with. And these are really the main scores. This is my dashboard. This is what's really important when I see the patients. And here is the radiographic view. We see some bone loss here. We see some advanced bone loss there. We see some calculus there. And we see this periapical radiolucency here. So the maximum bone loss was 45% in this area. Middle third of the root, 45 over 61 was 0.74. So we did our staging and grading for this patient using this matrix here, this rubric. Bringing it through, I'm going to bring you forward here. And we looked for the diagnosis, and the diagnosis was a stage 3 grade B periodontitis, generalized, unstable. When we look at the different factors, epigenetics, lifestyle, systemic diseases, that was her diabetes, environmental factors, tooth factors, this is what we came up with. So, and we had generalized, formerly it would have been called generalized chronic moderate to perio, severe perio, modified by local factors and systemic conditions. That's really complicated. Also, she had some hyperplasia related to her calcium channel blocker, and she had a combined endoperio lesion at 2.6. So you can put this into the app that you can download, and the prognosis, and I've been doing this my entire career, which is different from the McGuire prognosis. We put things into 3 buckets. When I look at teeth, I don't think this is a good prognosis or favorable, or there's like 5 or 6 or 10 different things you can put it into. I keep it very, very simple. Right? The first category is irrational to treat. Irrational to treat. There is no doubt that 2.6, it doesn't matter how well Donna is going to scale this. We're not going to get anywhere. This is you're not rational if you're treating, you think you can treat this. So 2.6 goes in that bucket. The second bucket is doubtful, which means I don't know how this is going to respond to a periodontal therapy. I'm giving it the benefit of the doubt. I'm going to put it through non-surgical therapy, and then I'm going to reevaluate it. And the third is it has a favorable, a secure long-term prognosis. Secure. That's a good word. That tells you that it's going to be there. You can count on this. You need a bridge? You know, I'm coming up with this tooth. This is a bridge-holding tooth. So I always use these 3 parameters: irrational to treat, doubtful, and secure. So at this time, and this was, I think it was 1875. No, when was it, Donna, we did this? We did this a long time ago, in the days before you had to have a different costume that you wore, and days before EMS. And we did an oral decontamination through exhaustive sanative therapy, 3 hours of scaling and root plating under profound anesthesia by an experienced dental hygienist with loops and fiber optic lighting. Ultrasonic and hand instruments we used. We would approach this differently today, but we're going to just, this is how we did the case at the time. And no antibiotics. The patient was instructed on the use of a powered brush, floss technique, interproximal brushes, no rinses, and her dentist removed tooth 2.6. That was the plan. 8-week follow-up. Okay? This is the instrumentation that we had at the time. This has changed a little bit. A little bit, we've refined it over the years. It's, yeah, EMS is a big part of this now. Still using our friends here. And we went from this to this. Okay? So this is a much better outcome. You can see the spacing, the diastema has decreased. The teeth have reduced, the tissues have reduced in their swelling. And this is, again, surprisingly no antibiotic, right? Just from a thorough oral decontamination, right? No bacterial testing, no biomarkers, right? Just removing the subgingival irritants, getting her blood sugar under better control. And this is where we went. We removed this tooth, it turned to that. And you look at the bone, it's improved, right? This vertical defect has improved in that time. And then we look at the scores, and I love perio because it's all metrics based. Yeah. Mesial 2.7, yeah, look at that. Great call. And there was no socket preservation. There was nothing except for a very thorough debridement of that area. Yes, Eric.
Was there any occlusal trauma on the anterior at all? Or?
Yeah. They're flaring because everything was erupted.
Yeah, but I mean afterwards, once that reposition was.
No, it found a homeostatic position, which went back to what she had before. So even with the loss of the 7, we lost some posterior support, it came back together again. So I think it's like a phenomenal case that just shows the power of what a dental hygienist can achieve. When you have enough time, you have the instrumentation, you can do what you need to do, and you've got the experience, and the patient listens to what you're telling them to do. Right? So metrics-based, everything is metrics-based. That's where we started. 8 weeks later, plaque scores better, bleeding sites down to 4, sites measuring 4 to 6, 24, and 2 that were from 19. So really good. We look at it 6 months later, it's better still. You look at it 1 year later, 2 years later, it's sustainable. Right? So this is sort of what we do on a day-to-day basis. So most of our treatments for patients involve sort of this sort of approach. Yeah, any questions about that, this area here? Are you surprised by this? No? Okay, all right, so seeing no surprised faces, we will keep going. This is obviously what you expect of us, so we're glad we were able to deliver. Okay. All right, let's go to stability. You do need to control local factors because things can be stable and they can get unstable again, right? You have patients that do well for a while. They're never cured, but you stabilize them. You control their disease, and things improve. The control of cigarette smoking, 2 to 5 times increased risk for periodontal disease. You add diabetes onto that, that's a huge problem for the patient. So, and they'll go through parts where they're very compliant, and it's almost like exercise, it's almost like diet, where there's phases where you're doing much better, and there's phases where you get out of that realm again. And then you know what? You need somebody in your life that you see, and they motivate you again. And that's what all of us do on a daily basis, right? You see a patient who's sort of been away for a while for whatever reason, life gets in the way, and then in a non-judgmental, but in an enthusiastic and a positive way, you find a way to push their button to motivate them again to get healthier, right? And by doing that, that has a lot of fringe benefits. So fortunately, we have a lot of patients that are, initially they get with the program and stay with the program, but I can't say that those are the majority of the patients, right? Because people have different things in their lives. But the remission and the control part is an important factor. So in terms of our patients that we have in our practice, and I'm just opening this up without any prior notice to Kathy and Donna, in terms of the stability of patients, how would you describe the stability of the patients that come here long term?
The stability, are you talking versus smokers versus non-smokers?
Yeah, so I'm talking more about patients that come regularly, that are on a regular program for us, either smokers or non-smokers. So
Yeah, and most of our patients coming on a regular program are alternating with their dental office as well. And yeah, I think that they're very stable, especially if they're a non-smoker. We can get them down to a handful of pockets.
Right.
But we have many smokers
yeah.
that still have 40, 50, 60
Yeah.
pockets. They're not getting worse, but they're not getting better because the tissue doesn't change,
Right.
right?
Yeah,
Right.
I'd say that's,
You know.
Yeah.
yes.
Yeah.
A lot of, we
The
see
really nice thing is that also if anything changes, because we are monitoring them so closely, if anything does start to move in a direction we don't want it to, it's a great opportunity to get them back on board, have those discussions, and get them stable again.
Yeah.
So we're just looking at them so closely with all the
And I think that, that one of the most important things is this concept of co-management as well, because it's not great for the patient if they only come to see us, because we are not experts in restorative work, right? Our focus is just so strong on making sure that we have the periodontal condition under control, that we're not as focused on caries and restorative issues. We look, but we don't look like the dentists here would look, right? So that's something that we still need. So we always tell patients we need to have some sort of alternating co-managed care, so that way you have the best of both worlds. And we use that best of both worlds line a lot, because in my practice it's not the best worlds for restorative dentistry, right? It's something that we are aware of, but we're not going to be able to help you nearly as well or see it, and you're trained to see certain things. So that's why this best of both worlds co-management is really important.
One thing I just wanted to say, Dr.
Yeah.
Fritz, is that what I do with my regular patients, when is the last time you were in at your dentist? I always check, and they're like, oh, I canceled my last appointment, I missed it.
Yeah.
We always just emphasize the importance of getting back to their restorative dentist, because we can't take care of everything.
Absolutely. Yeah.
Sorry, I'm just going to add to that. So Larissa's study that
Yeah.
we did, we were looking at did delays due to COVID-19, did they have any effect on periodontal outcomes? And they did. So bottom line of that was that consistency is key here.
That's right. Thank you, Carly. Yeah. That was the lady who made the sandwiches. She has that. No, that is Carly, our very important project manager. She coordinates all of these things for us, and has done a master's with Wendy Ward as well for looking at things. So, yeah. So this co-management is really important. Louisa has another point.
You mentioned the importance of maintaining that trust with the restorative dentist. You mentioned keeping up that relationship, because you don't want to all of a sudden have to go and find a new dentist when you need a root canal treatment and crown on a tooth that's having a problem. Right? You want to go to someone you have built that trust with and continue to have a relationship with.
Yeah. And it's really a shared responsibility as well, right? So that's the part that is really, really great, that you've divested responsibility, that you've done your duty to say, this is beyond what I can help you with. We need to have another hand on deck. All right, so we're wrapping up now. So I ran into this line again, and I used it a couple of times today in preparation for this lecture. You think about your teeth a lot when you don't have any. So that's a little catchphrase that I think is really helpful. So with that, we're going to conclude our first session on this topic. But this is just the beginning, right? This is just the start. And I'm very excited to explore the next part with you at our next course. And Carly, what the next date on the course is when is it?
So the next one coming up is actually a Category 1 course.
Right.
It's February 13th, and it's called Stuff Happens in Neuroscience and Communication. So that's presented by Dr. Bruce Freeman.
I'm going to just jump in here and tell you why Bruce Freeman is so important to me. So when I was a dental student, I worked as a research at Mount Sinai Hospital in a research lab. And on Tuesdays, we had craniofacial pain day. And I went down to the craniofacial pain clinic, where they would send patients that were extremely difficult to manage. This is the clinic where they went in and they had just like really weird kind of things. And the patients were a very diverse group of patients of all different types. And I'm like a second-year dental student, and I really don't have my clinical quilt. And the clinical quilt is something that, as you're becoming a clinician, you take little patches from people that you learn from mentors, and you take those little patches and you build your own quilt, and it becomes your own style, and it becomes your own, this is my persona, this is my clinical persona. I'm doing what Colleen Porter does. I'm doing what Kathy Hamwell, I saw her do, and you're building this quilt. So I didn't have a quilt, but I'm there, and I don't know much, and I watch this guy talk to patients that have exceptional needs. And he has a style that I'd never imagined before and I've never seen since. And that fellow is Bruce Freeman. So he's an orthodontist, and he has amazing interpersonal skills, and I've taken a lot of my clinical persona from him. So he's giving a Category 1 course, and it's going to be fantastic. So I'd encourage you who need Category 1 courses to come, and those of you who don't need Category 1 courses and you just want to be a better communicator and know the neuroscience behind difficult conversations, this is for you as well, right? So that is on February 13th, Thursday. Yeah, so just a great thing. And also we're trying to reach as many people as we can. So if you've enjoyed tonight, and spread the word. We'd love to have more people enjoy this course, and more people like you. So, and then after this that course, what's next, Carly? The one after that is February. Well, you've got that pamphlet right next to you, right? There's that.
There's another one in February.
Right.
So that one is on comprehensive periodontal examinations.
Right.
Yeah.
That's how we do that's how we do a perio exam. So I'm going to take you through step by step of how we're going to do that perio examination.
That would be the next step in this perio journey.
That's right. Yeah. Cool. Any comments, questions, frustrations, aggressions, or hostilities at this point? Seeing none, I thank you for coming out tonight. I thank you, Kat, for helping us. Thank you, Carly, for organizing this lecture series, and for all the wonderful things that you do. And hopefully next time we'll have the Visia set up so that people can do their complementary skin analysis, which hopefully by then my skin cream will be working better. So yeah, so thank you all for coming out tonight. It's been a pleasure. And
There were a few people still waiting to play with the crowd. Feel free to
Yeah.
stop by there on
Yeah.
the way out, or if you didn't have it with Kat, she's still here for a little bit longer, and you can stop by with her as well.
awesome. Okay, thanks everyone. Okay.